This is your final exam review for the Psychology 2301 Departmental Final, Part 5, Chapters 9 and 10. Abnormal behavior or psychopathology refers to a psychological disorder causing distress, disability, or dysfunction. These disorders are defined symptomatically by the Diagnostic and Statistical Manual of Mental Disorders. This is also sometimes abbreviated as the DSM. This definition of abnormal behavior relates to objective number 1 in Category 8, Psychological Disorders. That objective is list the criteria for abnormal behavior. The Diagnostic and Statistical Manual, which was published by the American Psychiatric Association, is now in its 4th revision and is referred to as the DSM-4-TR. This provides a common language and standard criteria for classifying mental disorders, so that one person speaking to another about an individual with a disorder is talking about the same type of symptoms. Likewise, research can be done whether on medications or therapies, and the researchers are using the same diagnostic criteria both to identify individuals and to see whether or not they've improved. The organization of the DSM is into 5 dimensions or axes relating to different aspects of disorder or disability. Axis 1 is the one we'll primarily be concerned with here. These are the clinical disorders. We'll also be talking a little bit at the end of the chapter about the personality disorders. These fall on Axis 2 and may coexist with Axis 1 disorders. This slide 3, refers to objective number 2, describe the purpose, organization, and content of the DSM-4. Objective number 3 asks you to define and describe the group of disorders called phobias. Phobias are a type of anxiety disorder where the primary underlying symptoms are physiological and mental anxiety. Anxiety is an irrational fear, dread, or agitation. The physical arousal or physiological arousal could include an accelerated heart rate, rapid breathing, as well as sometimes signs of nervous energy, shaking, excess movement, excess talking, etc. Phobias are one type of anxiety disorder. A phobia is an unreasonable fear of something which produces avoidance in the afflicted individual. A specific phobia is a clearly defined object or situation. For example, someone's afraid of dogs, someone's afraid of heights. A social phobia involves a fear of social situations or other people. This can manifest as extreme shyness or discomfort in social situations. It may also be relatively focused, for example, a fear of public speaking. Another type of anxiety disorder is the panic disorder. With panic disorders, the primary symptoms are physiological. These are sudden attacks of apprehension and terror, leading to behavior changes like avoidance, and physical symptoms such as shortness of breath, rapid pulse, trembling, and sweating. The individual may actually experience a sensation like impending doom, or they think they're going to die, they're having a heart attack, and may end up in an emergency room hyperventilating. The panic attacks are very difficult to control, and frequently physicians must utilize medication in order to stop them. Objective number 4 in this section had asked you to list the criteria for the diagnosis of panic disorder. The third type of anxiety disorder is the obsessive-compulsive disorder. This disorder typically, but not necessarily, consists of 2 separate parts. The obsessions are repetitive, distressing, or frightening thoughts. For example, the individual may perceive themselves to be dirty and repeatedly attempt to engage in a behavior, a compulsion, to attempt to calm those thoughts. For example, the person may wash their hands repeatedly. Objective number 5 asks you to describe the features of obsessive-compulsive disorder. The primary feature, of course, is anxiety. However, the obsessions frequently are intrusive, making it difficult for the person to concentrate on anything else, such as schoolwork or work. In addition, the compulsions, those behaviors that are attempting to interfere or stop the obsessive thoughts, may also interfere with what the person is doing. For example, they have to stop work continuously in order to go wash their hands, or they may even cause physical problems. For example, the hand washing may cause a rash or may cause other difficulties for the person in terms of their behavior. Occasionally, the obsessions may be more of a violent nature, an obsession to cut, for example, or an obsessive act that might involve dangerous driving or something similar. And certainly the compulsions here, whether they involve actual cutting, actual dangerous driving, other types of dangerous behavior, may actually result in physical harm or death to the individual. Objective number 6 asks you to describe the characteristics of dissociative identity disorder. This disorder used to be called multiple personality disorder. Basically, it consists of 2 or more distinct personalities that exist within the same person. This is a controversial diagnosis, but many psychiatrists and psychologists do believe that this disorder exists primarily as a result of early life abuse. The memory disruption in dissociative identity disorder is the reason the focus in the label is on the dissociation. The alter, the other personality or personalities, don't necessarily remember the original personality. Likewise, the original may not be aware of the alter, so there are missing periods of time. This is an extremely rare disorder. It is not the same as schizophrenia. Schizophrenia is a psychosis where the person's split is with reality, not within themselves. And as I mentioned, it used to be called multiple personality disorder, but is now referred to as dissociative identity disorder because it's primarily a memory problem. Objective number 7 asks you to describe the features of schizophrenia. Schizophrenia is a very severe mental disease or disorder. It's considered a psychotic disorder where the person has a loss of contact with reality. The schizo, or the split in this part, refers to a split with reality. The positive symptoms of schizophrenia, the things that the person has in addition that a regular person doesn't have, include hallucinations, which are false perceptions. Hearing voices is a typical one. Delusions, or false beliefs. Paranoid delusions, delusions of grandeur, for example. The person may have inappropriate affect. They feel emotions or engage in behaviors that are inappropriate to the situation, laughing at a funeral, for example. Loose associations, their thoughts don't logically flow from one to another. Their speech also may be disorganized to the point that they exhibit something called word salad, where the words are just a jumble and people can't readily figure out what it is they're trying to communicate. In addition to these positive symptoms, there are also areas in which the individual with schizophrenia is lacking. Negative symptoms include social withdrawal, deterioration of adaptive behaviors. For example, a person may no longer clean themselves. They may even stop eating. They have a flat affect. They don't experience the normal range of emotions. And they have poor problem-solving abilities, which often leads to them being unable to work, unable to manage their finances, unable to manage a living arrangement. Objective number 8 asks you to list the possible causes of schizophrenia. There may be multiple causes of schizophrenia, and certainly causes may be interactive. No one knows for certain. Genetics certainly play a role. Schizophrenia does run in families. Identical twins have a relatively high concordance rate, about 50-50. If one twin has it, there's about a 50% chance the identical sibling will as well. There are changes in the brain of schizophrenics. They have fewer neurons and enlarged ventricles or open spaces. There are differences in neurotransmitters, too much dopamine, for example, in the synapses. Poverty, malnutrition, and disease are correlated with schizophrenia. These things are also correlated with stress, and in particular, the malnutrition and disease may produce epigenetic changes leading to the disease. It's possible there's prenatal damage, maybe as a result of viruses. There are some correlational studies which suggest that babies who have been in a certain period of prenatal development, when an epidemic or influenza epidemic passed through a certain area, those children were more likely to be schizophrenic. Stress plays a role. Substance abuse certainly plays a role. The specific role of substance abuse is unclear. It may trigger the episode because of the changes it produces in brain chemistry. It may also cause epigenetic changes, or this may simply be a correlational feature because schizophrenics may be self-medicating or simply living the kind of lifestyle that lends itself to substance abuse. In addition, as I noted in the beginning, it's very likely there are interactions between many of the items listed above. Objective 9 asks you to summarize the features of the major subtypes of schizophrenia. Disorganized schizophrenics are those who exhibit language and behavior that may be chaotic and illogical, giggling to themselves, engaging in inappropriate actions. Catatonic schizophrenics have an extreme disorder of movement. There may be no movement at all. They may lie in bed for days at a time. They may not talk. They may be stiff or rigid, sitting in a chair for hours with no movement. A paranoid schizophrenic is the type typically depicted in the movies. These are people with hallucinations or delusions. They hear voices. They think they're being persecuted, followed, invaded by alien bodies that are possessing them. Those are the most prominent symptoms. They may also have thoughts that a government agent is following them around, or delusions of grandeur. They believe they're some important historical figure, or they're Christ, or they're going to save the world. The undifferentiated schizophrenic has mixed symptoms from 2 or 3 of the other subtypes, and therefore can't be put neatly into any one category. Objective 10 asks you to describe the features of major depressive disorder. Most of you know that depression is a sad mood, a low mood, feelings of despair. A major depressive disorder is a low mood that lingers for a long period of time and has rather severe psychological as well as physiological symptoms. There's generally some withdrawal. This may be withdrawal from family and friends. The person may stop going to work, may avoid social occasions. There's a loss of interest in pleasure and usual activities. They may abandon hobbies, may no longer read, watch their favorite TV shows. They really just don't seem to care. Eating and sleeping disturbances, may overeat, undereat, have periods of insomnia, or sleep all day long. There's a lack of energy and generally feelings of guilt. They feel like they ought to be doing more. There's something they should have done that they didn't do. It's diagnosed when it lasts more than 2 weeks and there's impaired functioning, meaning, for example, the person doesn't go to work or doesn't maintain relationships. There may be psychotic features, times when the person loses touch with reality. They may, for example, hear voices or experience a loss of ability to relate to people in the world. And certainly a very serious symptom is suicidal thoughts or attempts. When an individual has alternating periods of depression and what's referred to as mania, they're said to have a bipolar disorder. Bipolar meaning they're going 2 different ways. Objective number 11 asks you to summarize the features of bipolar disorder. As I mentioned, with bipolar disorder, the individual is having episodes of depression. They're alternating between those lows and highs, and they may actually have normal periods in between. The manic episodes are characterized by exceptional amounts of energy and enthusiasm. The person may be very agitated and irritable. They may have episodes when they rage in anger at other people or events. They may certainly be out of control. The excess energy may be associated with sexual promiscuity, lots of drug use or alcohol abuse, excessive gambling, spending sprees, particularly spending sprees that the individual can't afford and buys things that they don't really want or need. The manic episodes, again, alternate with depressive episodes, but frequently the disorder is not diagnosed until the person has had at least one of those manic episodes. Otherwise, they're seen as just being depressed. Both depression and bipolar disorder are associated with a high risk of suicide. Objective number 12 asks you to summarize the risk factors for suicide. The risk is certainly increased if they have a diagnosable disorder. These include not only depressive disorders, but schizophrenia, as well as some of the anxiety disorders, including obsessive-compulsive disorder. In general, women are more likely to attempt suicide. Men are more likely to commit suicide. Women frequently choose methods such as taking an excess amount of pills, in which their attempt can be interrupted and they can be rescued. Males are more likely to choose violent means, running their car off a bridge, shooting themselves with a gun, jumping off a building. These things are less likely to be interrupted. They're less likely to be rescued. Older men are at the highest risk, particularly older men who might be suffering from an illness and not want to put their family through the expense or the pain of watching them get sick and die. A history of being abused is associated with suicide, and as well as other high-risk behavior. This behavior might include driving a car too fast, drinking too much, using excess drugs. Those things are associated with suicidal behavior, correlated with it. The method is also associated with success at suicide. As I mentioned earlier, guns succeed more often than pills. Risk factors also include prior attempts at suicide, a family history of suicide, and exposure to other individuals who've committed suicide. For example, the cluster suicides that sometimes exist in high schools or colleges, where you hear about one individual doing it, and that makes it more likely that you'll do the same thing. Objective number 13 asks you to summarize the features of the personality disorders. As I mentioned earlier, personality disorders are listed on Axis 2 of the Diagnostic and Statistical Manual. Personality disorder refers to an inflexible pattern of thinking, feeling, or relating to others. This is the individual's personality, but the personality makes it more difficult for them to have normal relationships and normal lives in the world. The patterns cause problems not only in the personal and work situations, but also in social settings. These individuals are more likely to run into problems with their friends and neighbors. They may actually be brought to the attention of a therapist, not because they perceive a problem, but because somebody else asks them or requires them to go to therapy. These individuals are not only unable to understand that they have a problem, they're unable to understand the needs or problems that others have, or the problems that others have with them. 3 basic clusters of disorders: the odd or eccentric disorders, the dramatic or erratic disorders, and the anxious or inhibited disorders. One personality disorder, which is especially common on TV shows and may also be a disorder that's of more concern to people than most, is that of the antisocial personality disorders. The antisocial personality disorder refers to an individual who consistently violates the rights of others. They perceive themselves to be, or their needs to be, more important than those of other people. They may lie, cheat, steal, engage in criminal behavior without necessarily perceiving that there's anything wrong, other than the fact that they sometimes get caught. They're more likely to engage in alcohol and drug abuse. They're egocentric, meaning focused on their own needs, as well as impulsive, engaging in behaviors that occur to them at the moment without consideration of what the consequences might be, either to themselves or others. There are both biological and environmental factors involved in the development of this disorder. It does run in families. It's more common in males than in females. In fact, there's 3 times more males than females with this disorder. Environmental factors may include things like being raised in a family where a criminal history is the norm. Objective number 14 asks you to list the characteristics of the somatoform disorders. With somatoform disorders, you have real physical symptoms, thus the title Soma, or body, in somatoform disorders. These symptoms are not explained by a medical condition, but instead may bring the person to seek medical attention. Ultimately, they may get referred to a psychologist or psychiatrist, who will more than likely see the symptoms to be stress-related. There are more females than males with somatoform disorders. Females are more likely to go to doctors complaining of these problems, and also more likely to be focused on bodily symptoms. Hypochondriasis is a somatoform disorder that many people are familiar with. Hypochondriac has excessive amount of worry or anxiety about having a physical illness. They may watch a television show about cancer, for example, and then feel the same symptoms in their own body. Or they may watch a television show where someone has a heart attack and all of a sudden be concerned that this is going to happen to them. Chapter 10 is therapy. Listed under other concepts in your Student Supplementary Handbook is objective number 2, summarize the various approaches to therapy. Therapy is basically a process of helping another person to change. Therapists can be psychologists, psychiatrists, social workers, or counselors, individuals from a number of different professions. Psychoanalysis is a form of therapy known as the talking cure. It's based on Freud's techniques, which include free association, having the person associate one thought with another without interruption, judgment, or comment. Dream analysis, transference, which is analyzing the relationship that develops between the therapist and patient as perhaps reflecting an earlier relationship in their childhood. Insight and interpretation, helping the patient have insight into why they do things and allowing the therapist to interpret various behaviors, particularly the use of defense mechanisms or the relevance of early childhood trauma. And finally, the uncovering of unconscious conflicts within the individual, and particularly those conflicts mentioned earlier about based on the differences between the needs of the id and the superego. Client-centered therapy, or person-centered therapy, is based on humanistic theory. Therefore, the focus is on personal growth of self-esteem. The therapist is generally someone who is accepting and supportive, and who doesn't attempt to force their morals, their values on the client. They're very non-directive, helping the client come to their own decisions and helping them develop their own values. Carl Rogers' techniques include developing a therapeutic alliance with the individual, so you're working together towards a common goal. Having a therapist who is genuine, who's a real person, may reveal their own thoughts and feelings, even as they provide unconditional positive regard for the client. Unconditional positive regard means you accept them for who they are, you accept their ideas and values without passing judgment. And finally, the therapist exhibits empathy. Empathy is understanding where the client's coming from, what their needs are, and why they have those needs. Behavior therapy is based on the principles of learning and may include classical, operant, or observational learning, as well as cognitive learning. The focus here is on the present, not what caused a problem, but what can be done to change a problem. The baseline is measured. How much of the behavior does a person engage in at the present? You then establish a goal. What change do you want to occur? And then use various associations, reinforcements, punishments, cues, the process of shaping, in order to reach those specific goals. This type of therapy is frequently used for specific targeted behaviors, for example, weight loss, smoking cessation, relaxation. The premise in cognitive therapy is that people have learned to think incorrectly about situations, or at least learn to think in ways that cause them distress. With cognitive therapy, you learn a new method of thinking. Initially, clients identify distorted or incorrect beliefs, the ones that are causing them problems. For example, thinking, I can't live without that person who just divorced me. You learn to think in a more logical way. I can survive, it may be unpleasant for a while, but I'll probably get better because most people do. You learn to reframe specific situations. You lose your job, you learn to reframe it as a challenge or an opportunity for a new position rather than an absolute disaster in which you're a total failure. You engage in homework, during which time you practice these new methods of thinking, and you also practice using the new methods of thinking in new situations. This results in an overall behavior pattern or thinking pattern that can be carried with you outside of therapy and utilized in future times of stress. And finally, there are the biological therapies. These are generally associated with treatment by psychiatrists or physicians, or at least physicians in conjunction with psychologists. This includes various drugs like anti-anxiety or antidepressant medications, antipsychotic medications that are used, for example, in schizophrenia or major depressions, stimulant medications such as those that might be used for attention deficit disorder, and mood stabilizers that might be used, for example, with a bipolar patient. These drug therapies are often and most successfully used when combined with talk therapies. If the person is non-responsive to talk therapies and drug therapies, there are some more serious biological therapies that can be used. These include electroconvulsive therapy, or ECT, which involves a series of electric shocks that are given to depressed patients that do appear to alleviate their mood and reduce the depression, making them more amenable to other types of therapy. Also, a more serious form of biological treatment is psychosurgery. In particular, this is used for obsessive-compulsive disorders, where the person's intrusive thoughts and repetitive behaviors are interfering with their ability to live a meaningful life. This concludes the Psych 2301 final exam review. Good luck on your departmental final, and certainly you can use the PowerPoints or this review as often as needed to help you prepare for that exam.